Hello and good evening, friends. Today is the fourth talk in the master series of ACNS webinars, and we are going to hear about the management of unruptured and multiple aneurysms. As you know, the prevalence of these unruptured aneurysms in the adult population is around 3%. And thanks to the advances in modern imaging, the detection rates of these unruptured aneurysms are on a rise. It goes without saying that harboring these unruptured aneurysms causes great anxiety in patients. On part of the treating surgeons, the risk of future rupture has to be carefully weighed against the risk of complication from preventive aneurysm treatment. Now, there are various risk assessment scores that have been designed for guiding the treatment, which are namely FACES, ELAPS, and UIATS. And to hear more about this, we are joined by two great surgeons with vast experience in handling such type of cases. The speaker for today is Prof.Stefan Florian from Romania. Professor Florian is the head of the Department of Neurosurgery at Cluj County Emergency Hospital, Cluj-Napoca, Romania. He was the past president as well as the vice president of the Romanian Society of Neurosurgery on more than one occasions. He was also the second vice president at large for the WFNS. He has published several scientific manuscripts and is also the author and co-author of several books. We are so thankful to him for accepting our invitation to speak to us in our webinars. The chair for today is Professor David Hassan from Iowa. He is the chief of vascular section, Department of Neurosurgery, University of Iowa, USA. He is an active researcher in the field of unruptured aneurysms and has also played an instrumental role in the development of much touted unruptured intracranial aneurysm treatment score. He was the first to propose the potential benefit of aspirin in stabilizing these unruptured aneurysms. We are so glad to have him today as the chair, and I am so thankful to him for lending his support for the ACNS on more than one occasions. On behalf of the Education Committee of the ACNS and the President, Professor Yuko Kato, I hereby welcome today's speaker, Professor Stefan Florian, and the chair, Professor David Hassan, to this online platform of ACNS webinars. Dr. Liu Bunseng from Malaysia is my co-host for today. And with that introduction, may I please hand over this online podium to Professor David Hassan.
Good morning, colleagues. And here in Iowa, it's about 7:30. I do appreciate this platform. It has been very educative for me, especially the interaction and the dialogue and the question. I've learned a lot. This is my second meeting to host, to chair. It's such a pleasure. Professor Florian is going to discuss with us today about aneurysms, specifically unruptured aneurysms, and how to go about selecting aneurysms for treatment and management. It is, as Raju said, that the rise of detection of unruptured aneurysm is going up. That's because of the MRI and the findings of MRI. Also, the aging people is going up. In Japan, it's going really high. And with that, I know we detected a lot of aneurysm in the United States. So it'll be intriguing to hear Professor Florian to help us decide who to treat and not to treat and how to select our aneurysms. Professor Florian.
Thank you very much. I'm very honored to be here to present you my experience related to the aneurysm. I have a quite large experience in vascular neurosurgery, and I want to share with you my point of view, my surgical point of view regarding the unruptured and multiple aneurysms, because when we discuss about unruptured, we should discuss also the unruptured aneurysm in the patient with multiple aneurysms. So let me, certainly I would like to thank to Asian Congress of Neurological Surgery, to Professor Yoko Kata especially for inviting me here. It's a great pleasure for me to be part of this very educational project. Today I will present you some challenges regarding the unruptured and multiple aneurysms, and I don't have any conflict of interest. Being on a course, educational course, I will start with the definition. How we define the unruptured aneurysm. These are the aneurysm that has never ruptured, and aneurysm with no evidence of rupture on imagistic examination. they could be incidentally discovered with the investigation made for another pathology like head trauma, brain tumor, or in family with subarachnoidal hemorrhage. And here it's a very interesting case with a butterfly glioblastoma, in which we also discover an unruptured aneurysm. It was really a challenge to decide whether to treat or not this case. And like this were quite many. Another category of unruptured aneurysm are those symptomatic. Those with, in a patient which present with headaches, repeated intensive headaches. The patients with ruptured aneurysm for another aneurysm, in cases with multiple aneurysms. In some specific location, we have cases with cranial nerve paresis, and some giant aneurysms could present like a expansive mass, like in this particular case, in an old 15 years old boy presented with hemiparesis, and we clipped quite a giant aneurysm. So regarding the epidemiology of this, there are many studies which are estimate the prevalence in population without comorbidity, and at the mean age of 50 to 50 years, the incidence is around 3.2%, but it could be higher in older population, and for sure, women have a higher prevalence of unruptured aneurysm than men. Regarding when we discuss and when we have to decide about the treatment, we should know something about the natural history of unruptured aneurysm. And regarding the natural history, I can only repeat the sentence of Niels Bohr. Prediction is very difficult, especially about the future. So what we know for the moment is the fact that there is a high discrepancy between the unruptured annual prevalence and the annual incidence of subarachnoidal hemorrhage. That means that we have only one rupture for every 200 to 400 patients per year. The problem is who will be the unlucky winner. There are factors that are influencing the natural course, and these are grouped in the literature in three large categories: the patient-related factors, the aneurysm-related factors, and could be possible external factors. I will briefly discuss about them, about these factors. So regarding the patient-related factors, the sex, the woman, had a higher prevalence, as I already mentioned. Age between 5th and 60th decade. There are some pathologies which are predisposing to aneurysm formation, like polycystic kidney, Ehlers-Danlos syndrome, Marfan syndrome, and also we know that there are many cases with intracranial aneurysm with intracranial aneurysm in cases with AVMs. Hypertension, it's for sure predisposing factors, the family history, and the multiplicity of the aneurysm. So along with this, there are some modifiable factors, and smoking, it's first of these modifiable factors: alcohol abuse, cocaine abuse, and there are some arguments in favor of contraceptive medication that are predisposing to aneurysm formation. There are also aneurysm-related factors, and a study made in Japan and also in South Korea established that size, location, and daughter sac are independent factors that are predisposing for for rupture of aneurysm. And also there are some factors like aneurysmal growth, and this is increasing with dimension of the aneurysm. Morphology of the aneurysm is very important also, especially in cases with daughter sac, thin walls regions. And some studies were made on pressure difference on the thin wall regions. But we should note that none of these metrics clearly differentiate the stable from unstable groups with statistical significance. So based on the literature up to now, we don't know for sure which aneurysm will rupture and which will not. So resuming the data, the annual and cumulative risk of rupture in Japanese and Korean population, it's a little bit higher based on the literature, around 1% per year, and at 9 years it's reaching 9%. In Western countries it seems to be a little bit lower, but in more than 10 years, almost 1/3 of the patient will present with subarachnoidal hemorrhage, or it will be dead. So these are all the factors from the literature in this table. I will not insist on them. But what I want to present is this study we performed based on our experience. And we studied the incidence of rupture related to the month of the year. So what we observed that there are some peaks in the incidence in January, in July, and in October. Certainly, the weather conditions, the pressure, atmospheric pressure, has some influence. But if you look, there are two peaks quite similar as a value in March and in October. And I wonder if there is an additional stress that induce the aneurysmal rupture related to the official change of the hour. We know that this is an additional stress for all the organisms. So we will study deeper this topic. So the problem is to treat or not to treat an unruptured aneurysm. If we look to the complication related to the rupture, up to 50% of mortality, and there is a cumulative mortality, and considering that 2/3 of the patients, the survivors after a rupture, will present some permanent neurological deficit, and the cost is much higher in rupture than in unruptured. And also with this method of treatment, we are addressing to aneurysm, not to subarachnoidal hemorrhage, which is a dramatic complication. So including vasospasm, early brain injury. Treating an aneurysm before rupture will prevent all these complications related to the ruptures. So also there are some data related to the conservative treatment and the mortality. And comparing with all the treated modalities in the literature, if you compare them with the conservative treatment, you will see that the mortality with conservative treatment is much, much higher, up to 50% in Hunter Hess grade 1, and it's rising up to almost all the patients will die with conservative in Hunter Hess 5. Meanwhile, at least in our experience, about 50% of the patients will survive, even in Hunter Hess 5. And also the mortality with conservative treatment, it's much higher than any other method of treatment. And especially if we look to the multiple aneurysm, we see almost half of them will die if they are not treated. So, but we have to put in the balance also the risk related to treatment. We are proposing a treatment which is not without risk. And if we look to the literature, their mortality related to the clipping is as high as 7% in some statistical presentations. The morbidity is up to 50%, and this is highly depending on the patient age, location, size, but certainly it's highly related to the surgical experience. Related to coiling, I will not insist because I only have experience with clipping. The mortality is lower. The morbidity is also lower than clipping, but regrowth or recurrence, it's as high as 1/4 of the cases in the first 3 years. And the risk of the rebleeding is up to 0.9%. This is quite similar after a period of years, quite similar with the natural history of unruptured aneurysm. So the decision, it's quite difficult, and especially neurologists try to find some scores. One of these scores, elapsed scores, was published recently, and they take in consideration the risk of growth, which is can predict the risk of rupture with high confidence. So this elapsed score takes in consideration the earlier subarachnoidal hemorrhage, location of the aneurysm, age, population size and shape of the aneurysm, and if you have a score higher than 25, and this could be easier reached with an aneurysm with 10 millimeter diameter and shape, modified shape. So we have 25 points. So the risk of rupture is as high, the growth and the rupture, it's as high as 60% in 5 years. Another score also published recently, quite recently in neurology, unruptured intracranial aneurysm treatment score. It's a little bit easier to complete. And if they appreciate which method could be applied, clipping or coiling, and if the difference is more than 3 points, one strategy may be preferred over the other. So generally speaking, the treatment it's recommended based on 4 variables: patient age, cigarette smoking, aneurysm size, location have a higher risk of rupture. Meanwhile, those smaller than 7 millimeters are theoretically with a lower risk of rupture. But in the literature, you will see that the small aneurysms were more prone to bleeding. Many retrospective studies underline the fact that there is a high proportion of small aneurysm among those who ruptured, and related to the anterior communicating artery, there is no difference in size between unruptured and ruptured aneurysm. So what it's important to know, it's on long-term studies, aneurysms do not heal. So a decision should be taken in consideration. Once we decide, the problem is how to treat them. If we compare the surgery with endovascular treatment, the rate of recurrence is higher after endovascular treatment. Retreatment and also rebleeding is higher in the endovascular arm, in our experience, we with more than 1,100 clipped aneurysms, we had 4 rebleeding. 3 were early and very early because of incomplete occlusion or clip slippage, and 1 rebleeding was after 18 years after the first clipping. And also clipping is favored because it has a better functional outcome on long term. There is no difference at 1 year between clipping and coiling regarding the morbidity and mortality. And theoretically, we can offer this is the case with rebleeding after 18 years. It was a paraclinoidal aneurysm that was previously operated with an not proper clip. So that's why it would develop a new aneurysm just above the previous one, and we reoperated this case just recently. So the recommendation are for surgery aneurysm larger than 7 millimeters, larger than 5 millimeters if the patient is young or middle age. In patient with multiple aneurysm with a previous ruptured aneurysm, large growing and asymptomatic aneurysm, and those with favorable location. And certainly we should discuss very openly with the patient and to discuss all the aspects, all the risk and the advantages of one method or the other, but finally the decision will be of the patient. So regarding my experience, I operate, as I mentioned, 1,169 aneurysm in 1,010 patients in more than 23 years of surgical experience, and we achieved clipping in 98% of the cases. Our presentation is centered on 120 cases with solitary aneurysm, along with 22 cases harboring 305 aneurysms with 182 unruptured aneurysms. So in total, my experience on unruptured aneurysm is about 302 aneurysms that represent 25.8% of our all operated cases. So for solitary aneurysm, we will discuss solitary and multiple in separate sections. For solitary aneurysm, the key points of surgery is an opening adapted to the location. We are very much in favor of frontolateral approach especially for an anterior circulation aneurysm. For MCA, we prefer the pterional approach. Intradural removal, it's appropriate for of anteroclinoid, it's appropriate for many of ophthalmic aneurysm and some posterior communicating aneurysm. And for particular location, like in this vertebral artery aneurysm, we perform an suboccipital median approach. So related to the surgery, there are some tricks. Very important to have an adequate brain relaxation. And for this, and I will underline again, the position, it's very important. We are largely using the lumbar drainage, and I start usually to open the Sylvian fissure over the optic nerve. I will show you later. So this is a case with an paraclinoidal aneurysm in which we perform an intradural clinoidectomy. I'm in favor of intradural clinoidectomy because I have a better control. I know that there are many authors, especially in America and the United States, which are preferring the intradural, extradural clinoidectomy. It's maybe a matter of school, but I don't see any complication to perform an intradural clinoidectomy. And you see, it was a large complex aneurysm. We perform a reconstruction with three fenestrated clips with a very good and appropriate occlusion of the aneurysm. In some cases, the surgery could be quite simple. So immediately after the opening of the sylvia fission over the optic nerve, going a little bit laterally, we identify the carotid artery, and then slowly dissecting, we discover the neck of the aneurysm. I'm very much in favor of using the temporary clipping in order, especially in this very large and very tension unruptured aneurysm. We put the first clip and then we resecure with the additional one, and then we open the aneurysmal sac in order to check the complete occlusion of the aneurysm. It was completely occluded. So it takes no more than 10-15 minutes in order to clip an aneurysm like this. But in many instances, it's not so easy. Like in this ophthalmic artery aneurysm, a complex one, in which we should dissect all the vessels adherent to the neck. In many cases of complex aneurysm, we should reshape the sac with bipolar coagulation, and we should. I'm in favor of clip reconstruction, and certainly in some instances we are using the intra-extracranial bypass. But as far as I'm very confident with the clipping, I rather prefer to perform a clipping. So after opening performing the clinoidectomy, we put some clips, fenestrated clips, and also reinforced with a curved one in order to make a stable and fixed occlusion. Like you can see here, the 3D reconstruction angio CT postoperative performed postoperatively. So in some cases, when the occlusion is not so good, but we see a blister aneurysm, we are using, instead of Goretek, like it was proposed by Professor Spetzler, we wrap with autologous dura. I will not insist, only to see that we have here on site the material after the clinoidectomy, the dissection, the clipping of the aneurysm. We should dissect completely the sac of the aneurysm from the dura, adjacent dura. So we put a clip, but I was worried if there is not a risk of regrowth. So we check, and you will see we cut a cuff of dura mater and wrap the carotid artery with that one, and then we fix the dura along of the carotid artery wall with a curved curve. So in that manner, we reinforce the wall, external wall of carotid artery in order to prevent a regrowth of the aneurysm. So our personal series in non-ruptured aneurysm, and the results are quite good. Only 1.6% of poor morbidity, no mortality, and in most of the cases we have good and very good result. And these are in line with many other recent series published in the literature. So regarding the multiple aneurysm, the reported rates highly varies in the literature between 2% and 45%. In the North American and Europe, it's around 26.6%. In our experience, because we are performing mostly angiosity, angio-MRI, and only rarely DCA, the incidence is not so high. So there are also some risk factors for multiple intracranial aneurysm. Again, the female sex, the obesity, and it seems that black race, they represent risk for 2 or 3 or more aneurysms. And this is a case, obese, heavy smoker, woman, 54 years of age with 4 aneurysms. We operate in the same session all the aneurysms with a bifrontal perineal approach, a large opening in order to reach all the aneurysms. And unfortunately, because of the complication related to the subarachnoid hemorrhage, and also because of the hydrocephalus and bronchoadjacent bronchopneumonia, we lost the patient in the less than 30 days after the operation. So, as I mentioned, I have an experience with 122 cases. Most of the cases, the most frequent location was anterior communicating, posterior communicating association, and anterior communicating MCA. We had also some cases with mirror MCA, and the anterior communicating artery location was the most frequent site of rupture in cases with multiple aneurysms. In the literature, there is a higher probability of rupture in multiple aneurysms. So that's why we should treat. And patients with multiple aneurysms are subject to cumulative risk for all individual aneurysms. And young patients with multiple aneurysms should follow up and treat most actively. These are the recommendations from the literature. And additionally, in cases in which we perform a clipping for one or treating a single aneurysm, there are unfavorable flow conditions to develop larger, more elongated, and more wide-necked aneurysms in the distal ones. And there are hemodynamic changes in distal aneurysms that show an unfavorable profile associated with an increased theoretical risk of bleeding. So most of the data from the literature are in favor of treating all the aneurysms. But the problem is when to treat. Early, there are some pros in favor of early surgery, but also cons, because really in multiple aneurysms, it's a difficult surgery, brain edema, narrow spaces, intraoperative rebleeding, high risk. So there are also some surgical related lesions. When to treat, we made a prospective study, and our conclusion is that in the first 24 hours, we have a higher complication rate, a low postoperative Karnofsky score, and a higher mortality rate. So we are recommending to wait until the next favorable medical condition for the patient, train medical team, and appropriate surgical conditions. The treatment of multiple aneurysm is a great challenge for both clipping or coiling. And the problem is how to treat in multiple sessions, how long we can postpone the second stage, or we can, in the one session, solve all the cases. Regarding the multiple stages strategy, there are not very clear cut indication. There is no general consensus. So some authors are in favor of postpone 24-hour, other more 10 to 4 weeks interval in between the operation. But based on our experience, in which we lost 2 patients in the less than 24 hours after the first operation, we decide whenever possible to perform surgery in the same session. And that means that we can perform single stage, single anesthesia with double opening in some specific location, like a bilateral supraorbital approach, bilateral frontotemporal approach, or in association with distal anterior cerebral artery aneurysm. We perform a frontolateral and paramedian approach, but also whenever it's possible, I am in favor of single stage, single opening. I have some arguments, and I will present them. I will not insist on coiling and debate coiling versus clipping. I will rather focus on my experience. So I will present some examples like this one with multiple. I think it was with 4 or 5 aneurysms located on both internal carotid aneurysm, posterior communicating aneurysm, ICA bifurcation. So we decide it's much wiser to open bilaterally. So nothing very spectacular. We started in the what we considered that it was the rupture side aneurysm. So we it was firstly clipped the posterior communicating artery aneurysm on the left side. You see that it was a rupture during the application of the first clip. That was because we didn't appreciate very well the dimension of the neck. So after putting a temporary clip, we perform stage clipping and then applied consequently the proper clips in order to complete. And then we check on contralateral side. It was not possible to reach the posterior communicating artery aneurysm, so we decide to open on the contralateral side. And this was the surgery on the contralateral side, and we perform a complete occlusion. I don't know how much time do I have. So this is another case with an distal aneurysm associated with the middle cerebral aneurysm. So we perform 2 openings in the same stage. Single stage, single opening has some advantages because it's technically generally easier than it seems. It spares a second craniotomy, reduces the operative exposure and time, and also it has some disadvantages because we have an increased brain retraction, obscured vision, the difficult definition of the neck on the contralateral side, and difficult management of contralateral rupture. So in some specific location, there are indication for contralateral clipping, like in ophthalmic artery, superior hypophyseal artery, ICA bifurcation, but it's not advisable to perform this in complex aneurysm and giant and bilobate and in ruptured aneurysm. And this was the case in which I usually do not recommend the contralateral clipping. We still perform this because we try to occlude the ruptured one as soon as possible. And during surgery, after clipping the ipsilateral aneurysm, posterior communicating artery aneurysm, again with clinoidal internal clinoidectomy, and I don't see my mouse, so I will go a little bit faster. So having proper control and a good definition of the neck, we were able to put the first clip and completely occlude the aneurysm on the ipsilateral side, and then we only check the contralateral side. You see that there are some very short optic nerves, and we look above the optic nerve, contralateral optic nerve, to see where is the carotid artery and what's happening with the aneurysm, and we were able to identify the neck. So being there with surgery, we perform the clipping, and you can see at the end, I don't know if it's clearly seen, in the end, this is the postoperative angio-CT with a very good occlusion of both in the same session. I will not insist on opening because it's the same. The positioning, it's important, and also related to the lamina terminalis, we conclude that do not influence the hydrocephalus development, so we perform only to relax the brain. We are very much in favor of as I mentioned, temporal clipping in order to have a better control. So I only want to present this mirror unruptured MC aneurysm in which we perform a patient with 3 aneurysms, 2 on the both in the ipsilateral side. So we start to clip the first one, the proximal one, then we move to the distal one, which was a little bit more complex. We clipped also this one, and then we move to the contralateral side, dissecting the contralateral sylvian fissure, which is not so difficult. So we identified the bifurcation, the contralateral bifurcation. You see the aneurysmal at the MCA bifurcation. We put a curved clip and look beyond the aneurysm. The clip was not properly, and the aneurysm was not properly occluded. So we performed another contralateral curve. So we encircle the aneurysm and finally obtain good occlusion of the contralateral side. So the results are quite good, but the mortality is higher than in the rest of the aneurysm. In conclusion, neurological status, surgical expertise are the most important factor influencing the outcome from a surgical point of view. In experienced hands, clipping is no less safe than coiling, yet has a lifelong durability. Unruptured aneurysm presents a dynamic nature, and at present we have a poor understanding on the factors underlying this dynamism. Contralateral clipping of MCA aneurysm is a valid option, not a recommendation. So, final conclusion, in vascular surgery, the distance between ecstasy and agony is less than 1 millimeter. Occlusion of aneurysm is only a step in the complex treatment of subarachnoidal hemorrhage. In multiple aneurysm is important as important as surgical strategy is surgical technique is to kill them all. And this is a poster made by my actual residents. And finally, keep training, keep doing, keep walking in the footsteps of master. Thank you very much for your attention.
Professor Florian, yeah, this is it was a very eloquent presentation, and we thank you so much for sharing your insight and also your experience about selecting aneurysms that unruptured and which one to treat and which one not to treat. Also, we thank you for sharing about your experience with treatment of multiple intracranial aneurysms. I want to highlight a few things, and then I will open it to session for the rest of the audience to ask questions for Professor Florian. Definitely has extensive experience with the aneurysms, and he's happy to answer these questions. So the first thing is about selecting aneurysms that should be treated or not. As Professor Florian mentioned, that what we have nowadays, the tools we have, the scores, the ELAPS, the phases, the UITS are really not the best tools we have. They're preliminary. Hopefully they lay in the foundation for future work. It's very subjective. One thing I was hoping that Professor Florian talk about as we move toward, you know, the new light of treating aneurysm is talking about the biology of intracranial aneurysms. There's a lot of work has been done. Our group has done a lot. I treated myself over 2,100 aneurysms, 2,100 aneurysms, and we have extensive literature based on that. But one of the things we are, and people are thinking about, is using aneurysm shape indices, CFDs, imaging. One of the things that are coming out from Occipital enhanced MRI, vessel wall imaging, using QSM and different things. And what people have failed and continue to, I think, continuing that pathway is everybody takes a piece of the puzzle and focus on it. So some group will focus only on CFDs. Some group will focus only on aneurysm shape indices. Some people will focus on imaging. What we lack at this point is the 360-degree comprehensive view, taking demographics like female, gender, age, ethnicity, taken on to CFDs, taken on to aneurysm morphology and imaging. I think once we get to that point and incorporate that, we will have advanced learning. And the reason I mentioned that is because I want the new generation to look into it. We've spent a lot. We have 250 papers on it, and I encourage people to look at it. Now, in terms of multiple aneurysms, again, this is a tricky. So a question. I'll start this question for Professor Florian. What if a patient comes in, 75-year-old, had a ruptured ACOM aneurysm, and had multiple, like basilar tip 3 millimeter, PCOM 2 millimeter, and the ACOM, let's say 5 millimeter? What would you do?
75 years old?
Yeah.
But for those,
because now, as you know, with the advances in medicine, the aging population is way
more and more patients with more than 70, 75. I operate even patients with ruptured aneurysm of 80, 82 years of age. Yeah. Just recently. Today, I operated patient with 72 years with 3 complex aneurysms in her head. So, but related to the dimension of 2-3 millimeters, I rather prefer to observe that.
So what is your threshold for multiple aneurysm to treat? The threshold.
So, as I mentioned, I rather prefer to clip all the aneurysms which are at risk of rupture. 2 millimeter aneurysm, it's not really an aneurysm that could rupture. I rather prefer to look them and to follow them with an angio, CT angio, DCA. And I do not recommend either coiling for this very small aneurysm. So for these 2-3 millimeters aneurysm, I will look for them, and I will follow them closely, imagistically and clinically. And for that, which is 5 millimeters, I will definitely clip it.
With that, I open the session for all the audience to ask Professor Florian if you have any questions. Please go ahead, and if you have any questions.
Thank you very much. Thank you, Professor Florian. It was an outstanding presentation with a very comprehensive database of the patients. I have a couple of questions for you. What is your cutoff size for offering surgery for multiple intracranial aneurysm, where one aneurysm you have already operated and the other aneurysm, is it 5 millimeter or 3 millimeter, or you individualize?
So based on the literature, there are some, and also in my experience, I had some 3-4 millimeters aneurysm that has ruptured. So we discussed just before about a patient 78 years of age. If the patient is young and the aneurysm is clippable, so we have a neck, even if it's 4 millimeter, 5 millimeter, I will go to clip them in order to secure order. But for those for 2 millimeters, 3 millimeters, I will rather prefer to look after them. And if I see that they are growing in under control, I will definitely recommend a kind of treatment. And I had some patient in which I follow them, and many of them are still stable after more than 5-7 years of follow-up.
Okay. My second question, is how do you recommend the screening for the family members of the patient who have multiple aneurysm? What is your recommendation?
For the family members?
Yes.
Yes, I recommend an angio-CT or angio-MRI, contrasted angio-MRI, in order to discover if there are a family aggregation of the aneurysm. So for sure, I will recommend to all the members direct descendants or ascendants to perform a non-invasive diagnosis, imagistic diagnosis.
Okay, thank you.
Thank you.
Thank you.
Yes, Professor S.N. Mathuria.
Say in PGI Chandigarh, where I was working, we had the large number of aneurysms. We used to operate around 450 aneurysms a year, and around 85 we used to coil. So that's what was the experience we had. And many a times it becomes, though it's a very preliminary thing which I am talking, when there are multiple aneurysms like ACOM and distal ACA, many a times it becomes difficult which has ruptured. So we should try and find out which has ruptured. So we go first to the aneurysm which has ruptured. That is number one. Number two, if we are able to tackle the aneurysms in one craniotomy, it is better we tackle the one aneurysm which is ruptured and subsequently the other aneurysms. And it goes beyond saying that if aneurysm is more than 7 millimeters, then it should be clipped. And similarly, in the coiling and all, what is told, if it is more than 5 millimeter, if it is a bifurcation aneurysm or ACOM, then it should be coiled or clipped or whatever it is. The smaller than that, as has already been told by Professor Stefan, that if these are increasing in size, then in that condition we can do something. If they are all static, then nothing may be required. So that's what I think.
Just one comment. I mean, in the ISAT study, and they looked at the aneurysm less than 5 millimeter that ruptured. And from all the ISAT study, 51% of all the aneurysm that ruptured were less than 5 millimeter. So the question is that you look at the denominator. The denominator of a small aneurysm is much bigger than the ones that bigger. So I still believe, I mean, we did studies where we took a micro wire and put it in an aneurysms that didn't rupture from anywhere from 3 millimeter to about 20 millimeter. And intentionally under general anesthesia, we spiked the blood pressure to see if the pressure change in the aneurysm. And surprisingly enough, there's some small aneurysm will experience more pressure changes than bigger aneurysm. So I still think there's some 3 millimeter aneurysm could rupture. The question is, how do we identify those? So this is small, 5 to 10%. I think the future is we need to develop tools based on the biology, not based on just, you know, sex, age, but the whole picture 360 to identify these aneurysms. So I like the approach that if you know can, you know, in the craniotomy, and I want to mention about the coiling too. The coiling is a good technique. It's as Professor Florian said, it has some flaws, recurrence, and you know of that, but also in a good hands. Like not everybody can clip like Professor Florian. I mean, that's one thing we need to take. I mean, she shows very good videos that he can go contralateral and clip aneurysm. I mean, so it has to be based on your own experience. If you're very good in clipping, then you should use that. If you're good in coiling, you should do that. Like example, I do both clipping and coiling, and I've treated over 2,100 aneurysms, and I can done over 800 aneurysms coiling a week, 15 minutes, literally 15, 20 minutes, and patient go home 3 or 4 hours later. And yes, they may have recurrence, but you can follow them or treat them. So I think you have to be, each one's experience be tailored based on that. And there are some, again, I was mentioned that there are some small aneurysms that rupture. And the trick is to find ways and tools to identify these aneurysms. Professor Florian, what do you think?
Yeah, for sure, you have right. But, you know, here in Cluj, where I working, I tried hardly in the last 15, 20 years to introduce the endovascular treatment, but I didn't succeed, not because of because of the political conditions, you know. So we have the most closest center which can perform. It's 100 kilometers far from here, and for some cases, for sure, I send them to be coiled, to be treated there. But based on my experience, I know very well when and how to treat an aneurysm, surgically speaking.
Yeah.
So I'm not at all against. And in posterior circulation, I rather prefer to send the patient to be coiled than to be clipped. I'm not afraid, but I know that the complication rate is higher, even in my hands. So I send them to be coiled. Many cases are still preferred to be operated by me than instead of endovascular treatment. In Romania, it's a particular situation. And I don't know, I'm lucky to work here and to have a possibility to treat only surgically, and having a good school of vascular neurosurgery speaking, but I'm jealous on you because you can perform both, and I'm convinced that you are very skilled in both methods to treat, and I really would like to have here at our disposal some surgeons like you to select the cases and to make the appropriate treatment for every single patient. Because, you know, there are no two similar patients and no two similar aneurysms. So for every single case, you should decide which is the most appropriate way to treat and the most appropriate approach. So in small aneurysms, yes, I am in favor of treating not aneurysm of 2 millimeters, but aneurysm of 3 millimeters. I see especially in anterior communicating artery aneurysm ruptured, and I operate a lot. So yes, we should treat, but I don't know how to discern. And there is another aspect. Many patients in which we discover a small aneurysm 3-4 millimeters. And many physicians are recommending, oh, you should follow that. But the patient insists, I don't want to live with this bloody thing in my head. Please do something. So it's the patient decision finally in unruptured aneurysm. And many patients are asking me to operate in order to solve this not so physical, but psychical problem, you know?
No, that's very, very wise, and that's very valid point, Professor Florian. That this is an anxiety. I have a 73-year-old lady, 5-millimeter aneurysm, every day called, just says, I had a headache. I bent over, I had a headache. You need to, for 3 months. I finally clipped her aneurysm, and it never called me back. I was sad. But I think you're very wise, Professor Florian. I think you bring a very good point. Patience and anxiety, that is a major factor that we need to take into consideration when treating this patient. I appreciate you bringing that point.
Thank you.
May I call my co-host, Dr. Liu Bun Seng?
Hello, Prof. Thanks for a very educative presentation. I saw your outcome on unruptured aneurysm, which is actually better than the natural history of patient with a small aneurysm. My question to Prof is, how do you actually counsel those patients who you think that are supposed to be observed, especially those between 4 and 5 millimeter aneurysm? Because looking at your outcome is actually much better than natural history. Why do you not deciding to suggest operation on them, and in how do you counsel them and in terms of follow-up, Prof?
So I always have a very open discussion with the patient. I explain them what is the problem, what is the meaning of an aneurysm, and I explain, as I presented here, that an aneurysm never heals. So we discuss the methods. We can observe them. We can also treat 3, 4, 5 millimeters aneurysm. It's not a problem and I present my experience. Based on my experience, what could happen if I clip unruptured aneurysm, and what could happen if the aneurysm is ruptured. And the decision, finally, it's of the patient. I know, as I presented, many patients which are have a great anxiety related to this aneurysm in their head. So, but I also have some patients which are rather prefer to be observed than to. I never force them. You know, I never force. If I feel that the patient is rather prefer to be observed, I encourage them. I am here. I will observe you. We will see in 3 for 6 months, 1 year. After that, to see at the beginning, I rather prefer to see a little bit more frequently to see if it's stable or not. But we have not only one session of discussion, you know. We discuss once again. He came to me and asking me. He is looking also for a second, third, fourth, fifth, fifth opinion, and then came back to me to ask me to operate. So I offer operation whenever I feel that I could offer in unruptured aneurysm an operation without risk, without high risk, not without risk, but because there is no operation without risk. But with a small risk, I can offer, and I'm at the disposal of the patient whenever they want to be operated.
My second question, Prof. In terms of a patient, you have mentioned that most of your investigation of choice are either MRA or CTA, and you hardly perform the assay. My question is, if you found a patient with a sizable clippable aneurysm with a strong family history of familial type, do you actually investigate those patients with the DSA, Professor?
Yes, I send them to be, but we also can send them to the cardiovascular department. They have two angiographs, so we have a good collaboration with the Cardiologic Institute here in Cluj, and in these cases, I encourage them to have a complete investigation in order to have the best decision.
Yes. Thank you, Prof. Professor Kimura. Hello, Professor. Do you want to ask a question?
Professor Florian, excellent presentation, and thank you for your outstanding comment. And also, Professor David Hassan for giving me a great comment for us all. So I totally agree with your opinion. So I have one question now. Professor Florian, if the patient have multiple aneurysm, so how do you detect the ruptured aneurysm definitely in the ruptured day? So if once you detect the ruptured aneurysm correctly, you just treat the patient on the onset day. That's only for the ruptured aneurysm. Also, how do you detect the ruptured aneurysm? Yeah, I have still concern about your surgical decision. Thank you, Professor.
Yes. So, for example, I don't
think here. Now it's time. I think our chair wants to leave. Yeah, please, Professor.
For sure.
Go on, please.
In many cases, you can detect the ruptured site because there is a higher bleeding. But also, we can detect also based on the morphology. Yeah. With a 3D, very good 3D reconstruction, angio-CT, you can also see the morphology of the aneurysm. So you can decide if there is an anterior circulation aneurysm, cases with multiple aneurysms, I'm not afraid to open, and even if I'm not convinced, to check.
Yeah.
Intraoperatively, you know? Yes, I check all the aneurysms during the surgery, step by step. And today, I had as I mentioned, a case, a lady with 3 aneurysms. It was clear that the anterior communicating artery aneurysm was the ruptured one, but I started with the MCA on the left side. Then I moved to the anterior communicating, which was a large one, a complex one, and then the third one in the mirror on the contralateral MCA. It was a bleeding on the entire basal systems, but having 72 years of age, the brain was atrophic, and additionally, the patient presented with 2 subarachnoidal cysts on both sylvian fissures. The location and the local condition was quite good to clip all the aneurysms. But usually, if I'm not very convinced which was the rupture one, I'm not afraid to open and to check.
Yeah.
In the same because I'm in favor of as I mentioned. Firstly, I'm in favor of single stage, single opening. But if it's not possible to close all the aneurysms in the same opening, I'm not afraid to make another opening on the contralateral side and to clip them.
Yeah, thank you.
Thank you, Professor Kimura. I think now our chair is in a hurry to leave. We'll end this meeting now. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank today's speaker, Professor Stefan Florian, and the chair, Professor David Hassan, for joining us today and teaching us about how to manage this very complex unruptured and multiple aneurysms. Thank you all for joining. Thank you, Professor Florian. Thank you, Professor Hassan. Thank you, Dr. Liu, my co-host for today, and it's bye-bye from all of us.